our last speaker is Ishbel. Is it Ishbel? It is Ishbel Henderson, who's going to be talking to us about understanding the association between restricted activity and patient outcomes in older patients. And she's going to be presenting a systematic review and meta-analysis. I'm going to go move out of the way.
Thank you. I'm just finished my first year of my PhD, so not quite as experienced, but I'm going to be talking about my systematic review, which was to understand this prognostic significance of restricted activity. So a little bit of background. I know a lot of people have already discussed this in their presentations. Since the 80s or before, the adult life expectancy has been increasing, and this has caused a demographic shift in the type of conditions that we've been experiencing to more chronic conditions and more of them. So this graph down here shows that the years of life lived have been in poor health have been increasing. So nearly your 10 years, some people live 10 years of their life in poor health. So this seems like a really big problem that we do need to address. Talking about chronic conditions, multimorbidities are defined as 2 or more chronic conditions. So this graph here, you don't need to worry about the key, is basically the prevalence of multimorbidities compared to age. And as you can see, it's a global trend that with age, there are more chronic conditions. So I've been looking at older adults, mainly over 80 years old, but I've also been looking at adults over 65. So why is this a problem? Well, at the moment, the healthcare is structured to treat diseases independently. So this is problems for both the patients and for the healthcare systems. So organisational problems are that these patients have to go to their appointments in lots of different locations, so they have to travel between them, they see their specialist, and then there's not much communication between these specialists. And they're given lots of different monitoring methods to monitor each disease individually. So this can be a problem because these patients sometimes have 10 or more chronic conditions, and the more chronic conditions that they have, the more vulnerable they are already. So it's a really big burden, and it's really hard to monitor these. In parallel, they've got treatment problems. So these patients are often on lots of different drugs, which is polypharmacy. And there's not much understanding between the drug-to-drug interactions and the drug-to-disease interactions. So they overall have poor treatment and poor outcomes. So a big problem with this is that there's these general non-identifiable symptoms. So it's really hard to know when you're monitoring them or when you're treating them where these symptoms are coming from and what to treat. So this is a big problem, but we thought, can we look at these symptoms and use them as a way of monitoring your health? So looking at a general measure of health. So it wouldn't be diagnosing them from it, it would just be looking at when the patient is in a stable condition, if they're quite healthy, they could monitor a general measure, and then when there's a change, look at this unstable state and introduce maybe additional monitoring for their different conditions, or maybe a checkup or a medication review. So we're looking at identifying the change in the states. So we've been looking at restricted activity, which would be looking at a change in the person's usual activities, so baseline change. And yeah, so I think quite a lot of you probably have experience, maybe personal experience, of caring for someone and saying, oh, I can tell that my mum's really ill because she's unable to make her cup of tea today, or, oh, I can tell she's really ill because she's unable to get out of bed. However, this doesn't actually have any clinical translation at the moment. So I did a systematic review of the literature that's out there and a meta-analysis. So the systematic review was looking at what association does restricted activity have on patient outcomes in older adults, primarily looking at hospitalization, but also looking at cognitive decline and mortality. So these outcomes were developed with a PPI group as important outcomes to the patients. So hospitalization and cognitive decline were identified as really important to the patients because it was maintaining their independence. And then another part of the review was also to look at what measures of restricted activity had been used. So my search was kept very, very broad because there's no agreed definition of restricted activity at the moment. It was also kept quite broad. We had quite a lot of hits because there's a lot of evidence out there that activity can help recovery. However, there's not very much about beforehand. So I looked at 5 databases and got 8,500 papers, and this was narrowed down to only 10 papers being included in the final review. So that just emphasises that activity is a very important thing, but it's mainly looked at in the sense of rehab rather than before illness. So restricted activity definition, in the literature, it could be grouped into 3 groups: reduced mobility, bed rest, and activities of daily living. So activities of daily living were the only established measure, and these are a set of fundamental skills used to identify physical independence. So that's eating, bathing, dressing, transferring, toileting, and walking around, and you're given a score to see if you're dependent or independent in these. Quite often it was a general score, just of all of these measures. However, the ones that were in walking and moving around could be grouped back into my first group. So the results, there were only 2 papers that looked at restricted activity and hospitalizations, despite that being the primary outcome. So I'm going to report the preliminary results on mortality instead. So this graph here, you can see that it's restricted movement and mortality, and it's further subgrouped into adjusted data, partially adjusted data, and not adjusted data, which I'll talk about further in a couple of slides. But as you can see that the point estimates for these different measures are all on the side of outcome, indicating that restricted activity does have an association with mortality. These 2 graphs are just different measures, so it's bed rest and activities of daily living, again for mortality. And you can see a similar trend where they're both on the side of association with mortality. So what do these results mean? Well, it's preliminary evidence that shows that the different measures are associated with mortality and possibly with hospital admissions. So the hospital admissions one, there was only 2 papers and they were both quite different, which is why I haven't included the graph. But they both had a kind of similar trend. Although there are quite a lot of limitations with this. So as I mentioned, it was subgrouped into adjusted data. Because not a lot of people have looked at this before, often the results weren't the primary results of the paper, and so the data wasn't adjusted. Also, there was a lack of raw data being reported. The control measures, this was quite a complicated thing because a lot of the control measures, they didn't report what they were using as the control. So it could have been no restricted activity, or else it could have been moderate compared to restricted activity. So it was quite hard to know this. A lot of the studies had to be excluded because they didn't report a control, which was one of the big problems. Limited studies in this area, so as mentioned, there were no studies looking at cognitive decline, and there were only 2 looking at hospitalizations, even though these were identified as really important measures to the patient. And then there's a lack of patient perspectives. So all the papers were quantitative papers, however, there was, in a scoping review, there was very little on qualitative papers, and none of the quantitative papers mentioned the patient perspectives. So I was hoping that I would have gone through my results with the PPI group before presenting here, but that sadly hasn't happened, but it is going to happen. And that brings me on to the next steps. So I'm going to be looking at whether this could be incorporated into an early warning system for declining health. And if so, how this would be delivered. So I'm going to be using the person-based approach to explore different methods of delivery. So whether we have the resources and whether it's feasible to have telephone interviews, telephone checkups with the patient to find out if they've had any restricted activity, or else I'm going to be looking at some technology. So if an app could be used in this process to collect this information, or maybe wearable devices, so like a smartwatch that could measure activity, or whether paper diaries are the best suited to this population. I'm going to be exploring that, or whether it could be a combination of all of these, so it's flexible to suit the patients. I'd like to acknowledge my supervisors who were really helpful in all of this, and the ARC for funding my research.